and good afternoon from London on behalf of Sadiq International Virtual University. Today's speaker is a phenomenal surgeon, Qasim Jafri. He is based in Ireland, and for that I asked Mohammed Shahzad, who's professor of urology in Lahore, to introduce. But briefly, Sadiq International Virtual University is exceedingly grateful to all of you who've participated in our previous webinars and workshops and conferences. Now we are starting another program tomorrow that is a course for nurses in different countries. So we have a setup in Sierra Leone in West Africa. The other one is in Balochistan in Pakistan. There's one in Baltistan, and there's another one which is based in Iran. So we're starting this. Thank you all for your support. And over to Professor Shahzad Anwar in Lahore for introduction of today's speaker. And then we can proceed to the session.
Thank you very much, sir, Professor Shavi Zaidi, and thank you for giving me an opportunity for moderating this session. I introduce Dr. Syed Qasim Jafri. My voice is audible, sir?
Yes, it is.
Okay. So I introduced Dr. Syed Qasim Jafri, and he graduated from Dow Medical College, Karachi. And after his graduation, he proceeded to Ireland. After finishing the urological training, he went back to Pakistan for 3 years and worked in LNPMC. For advanced training and fellowship in urology, he worked in Strasbourg in France, in St. Antonio in USA, and in London, UK. So he has a widespread experience in almost all the good centers in the whole world. Since 2001, he is working as a consultant urologist in University Hospital, Galloway. He has done his master's in urology from the National University of Ireland. Currently, he is a member of Royal Academy of Medicine in Ireland and fellow of College of Surgeons, Glasgow and Ireland. He is also a fellow of European Board of Urology. He has been teaching and training medical education for postgraduates, for undergraduates, for nurses, for paramedics in different spheres of the globes, in form of tutorials, in form of lectures, meetings, ward rounds, and even in form of hands-on training for advanced urological procedures. After joining IMI, first delegate, he went to Iraq in 2009, and then he visited multiple times there in Iraq and distributing his skills and knowledge from the platform of IMI. Dr. Jafri is also a main coordinator of IMI annual Urbine Medical Mission. So today he is going to present a very important and a conceptual topic, and that is tailoring personalized medicine in the current era of an increasing cancer surge. And he is going to give us his thoughts on medical oncology in the genetics and its molecular factors with genomic profile. And it's really a very thought-provoking area. And an expert like Dr. Jafri can throw light on these topics, such as role of targeted therapies and immunotherapies, and exploring the potential liquid biopsies, real-time monitoring of cancers, precision oncology, and challenging and limitations in the personalized medicine in cancer management. So we invite Professor Dr. Qasim Jafri to deliver his lectures. Sir, over to you, sir. Thank you.
Thank you very much, Professor Shahzad, for this introduction. And I'm thankful to the SIUB University for providing the platform. Special thanks to Professor Zaidi for setting this up and mentoring all of this, and Dr. Mubashir, who is behind the scenes doing all that. So thank you very much all. And it's a pleasure for me to be part of this webinar and to share some thoughts, and so that we can have a discussion later on this as well. So without any delay, I selected this topic for a reason that in my practice as a urologist in University Hospital Galway in the west of Ireland, I actually started seeing a sudden surge of cancer, which was not evident. So I've been practicing here for the last 25 years. And I used to see a very slow surge of cancer, especially in the GU cancer. but recently I've seen a significant surge. So I thought that, there has to be some reasons, but that's another day's discussion. What are the reasons for this cancer surge? But let's see what we can do to minimize and control this surge so that the humanity can benefit from it. So hence this topic, which I've selected for this. So just to give you, I've divided my talk into main three parts. First of all, just to look at the incidence of cancers all around and what are the predictive rise in the cancer, which we will be seeing in the coming years if we don't do anything about it, and how to control it. And then related to my field, that is urology, I would like to share some of those things which would be important. And then to understand what personalized medicine means and how that can help in controlling this surge. So, once you have the surge, you have to find a way around how to deal with that. So just to see the incidence, there'll be very quick slides initially just to see what's happening in the world and how the cancer is rising. So the new cancer rose by about 2.3% compared to 2020, and it to reach 2.74 million in 2022. Similarly, the cancer deaths went up to about 2.4% compared to 2020. And according to the European Commission, estimated published in the European Cancer Information, these are the statistics in October 23. Breast cancer obviously remains the most diagnosed cancer in EU, and I'll tell you why. I'm just giving you the stats of the EU because in European Union, this is the most properly done surveys and very closely littered data which they have followed up. So United States and the North American states have also have got a very good data collection, but EU seems to be quite niche in that. Colorectal cancer obviously comes second, prostate cancer, and then the lung cancer. So the four most common cancers, cause of death in EU, are estimated to be the lung, that is about nearly 20% of all the cancer death, followed by colorectal cancer, about 12.3, breast, then 7.5, and pancreatic cancer also. And in general, the incidence is rising in these. This is another slide in 2020, whereby you can see 23% of all the deaths were by cancer, which is far, it's quite high incidence. This is obviously the number one is the circulatory diseases. You can see about 33%. So everything comes after that. Sorry. This is the live data, which you can find yourself. And I just collected it recently. And you can see the total deaths only today were about 80,000. And the deaths this year, you can see that as well, that numbers. And if you can see quickly those numbers, the coronary artery disease is the number one killer in the world. And but the total estimation of the deaths, if you collect them all, the number two would be the cancer. So the recommendations by the EU, as I said, that the statistical collection is, quite nicely and precisely done by EU. So hence we're going to concentrate on that. The extent, what their recommendations for the personalized medicine for those cancer surge. So the EU did sit down and had a discussion in their parliaments, and it had an implementation for all the EU states to bring about these changes to prevent and control the surge. So for breast cancer, they said that the women between 45 and 74 years of age, as compared to the current age bracket of 50 to 69, so they reduced the breast check to much younger group to control it much better. Human papilloma virus testing should take place between 30 and 45 because we know that cervical cancer, which is quite a killer cancer, is related to HPV, and And again, the presence of the vaccines, this HPV testing is even more important. And they have obviously reduced that age group also. And they also wanted the triage testing of colorectal cancer between the ages of 50 and 74 with the immunochemical testing and endoscopy and colonoscopy every 2 to 5 years. Lung cancer, they have also addressed that issue in the form of testing by chest x-rays and other tests for current heavy and ex-smokers, and they have reduced that age to 50 and 75. And just recently, I would say not more than a month or 6 weeks ago, they have implemented that. Before, they were not accepting prostate cancer testing in men up to 70 years on the basis of prostate-specific antigen, but now they have passed a law that prostate cancer testing or screening should also be implemented as a part of the other cancer screening programs. And screening for Helicobacter pylori, which we all know can cause high gastric cancer incidence and death rates as well related to that. So Helicobacter pylori is, can cause stomach cancer, and hence the surveillance of the precancerous lesion. This is a very interesting slide, and I would like to, bring all to your attention that this actually means that if the only thing you have a hammer, everything looks like a nail. What it means is that, one size doesn't fit all, and we have to think laterally when we are planning or personalizing the medicine. And medicine has to be personalized to every human being, and it's not a conveyor belt, and it's not a thing which we are dealing with. This is a human body which can respond to any way. And one of my professors used to say that patients don't read the books when they come to the hospital, so they can present in any different way. And hence, if the variability arises when the patients come to the hospital, then you have to personalize their treatment also. Genetic profiling, there has been a significant increase and advances in genetic profiling. The advances in genomics have allowed for the identification of specific genetic mutation and alterations in the cancer cells. So tailored medicine can utilize this information to recommend treatment that target the genetic drivers of an individual cancer, thereby increasing the chances of treatment success. So for example, we see here that standard biopsy is done by taking a biopsy from the cancer cells, but now there is an availability of a thing called liquid biopsy, whereby the circulating cancer cells are detected by just a simple blood test, and the fragments of the tumor DNA that are shed into the bloodstream from the primary tumor and from the metastatic sites can be picked up by a blood test. These liquid biopsies are available and are becoming more and more common for the diagnosis and testing. Biomarker testing, in addition to the genomics and biomarking testing, can provide a crucial insight into the patient's cancer. Biomarkers can include specific proteins or other molecules that can guide treatment decisions. For instance, certain biomarkers can help determine the suitability of immunotherapy. For example, once we do the biopsy of a bladder cancer, you can ask them to check for PD-L1 availability of that receptor. And if there is a PD-L1 in the bladder cancer, so there is suitability for immunotherapy. And immunotherapy is basically a biological treatment that is the cells are produced and then given to the patient themselves, which alter their immune system against the cancer. And it has recently provided significant success, and the outcomes of immunotherapy have been, it's great. So immunotherapy has actually revolutionized the cancer treatment by harnessing the body's immune system to attack the cancer cells, and tailoring the immunotherapy to a patient's unique immune profiling can enhance its effectiveness and reduce the risk for adverse effect. And as I said that, in the current era and in the current surge, that has really made a huge, big difference, especially in GU cancers. Personalized medicine also involves the use of targeted therapies that are designed to specifically address the unique molecular characteristics of a patient's cancer. These therapies can be more effective and less toxic than the traditional treatment because, as you all know, that if the cancers, if there is a specific cancer in a place, for example, in the lymph nodes and in the breast, if you don't target the chemo to those areas, then obviously it will have a significant side effect elsewhere. Even in the bladder, it can cause interstitial cystitis. In the other parts of the body, it can cause liver issues, and wherever it is excreted, for example, the cisplatin-based chemotherapy causes significant nephrotoxicity. So hence the targeted therapies make it have a less side effects to the other organs. Patient preference, that's also very important. And I put this slide specifically to my area of interest, which is the urology. So personalized medicine should also consider a patient's values, preferences, quality of life. Some patients may prioritize treatment with fewer side effects, while others may opt for aggressive approach. So for example, in the prostate cancer, if it is a localized prostate cancer, the patient will have all 4 options, as we say. That is the active surveillance, if the patient's age is to that, and nowadays even the younger age group, if there is less aggressive prostate cancer, we can get them to opt for active surveillance. Active surveillance is not accepted by everyone, and hence the personalized medicine come into play, whereby we have to discuss with the patient that whether he would accept that if we closely monitor your cancer, and hopefully it would not kill you, because the chances in the West for having prostate cancer is about 30% in someone's life, but the chances of dying from the prostate cancer is only 3%. What it means is basically you can see the gap. The incidence is of the prostate cancer in someone is 30%, but chances of him dying from it is only 3%, which means that it is less aggressive and it is an indolent cancer. Hence, active surveillance is one type of the treatment whereby we do wait and watch policy and make sure that this patient. So a lot of these patients with the prostate cancer don't die from it, they die with it, which means that the cancer or prostate cancer is not the cause of the death, but however, the cancer is still there. So based on all of this, the personalized medicine basically suggests that we can give them an option of active surveillance, but that's not everybody's ballgame. People have to buy into it, understand that, and psychologically get into this. So active surveillance is one of the treatments which we can offer, and the patients can accept that. Brachytherapy, putting the radioactive seeds into the prostate gland, only once a day, one of the days the patient comes in and have this treatment, and the radiation kills all the cells. And then the external beam radiotherapy is another form of the treatment which the patient can take. And again, there are about 37 sessions. The patient have to come 37 days to the hospital, which it's not everybody's ballgame. However, the latest and the most common and the most done cases are the robotic radical prostatectomies, which is a few hours procedure, and the patients go home on the 3rd day. So you can see that cancer is only one, that is prostate cancer. It's a localized disease, and there are 4 options. And all of these 4 options are applicable to a person who has this treatment. And there are several factors which determine which treatment the patient will take. This is a classical definition of a personalized medicine. And especially in this era whereby there is a cancer surge, this is a true example that how we can control these type of cancers. This is a CyberKnife treatment, which is available, I think, in Karachi as well, in Jinnah, but in every hospital here, most of the hospitals, we have this CyberKnife treatment, radiation therapy that can be also personalized with the treatment designed to precisely target the cancer cells while sparing the healthy tissue. This also is, minimizes the side effects, and with the computer control and the robotic technology, this preciseness basically is the main area which controls the avoidance of the side effects. Risk stratification, very important. Not all cancers are the same, and not all patients have the same risk factors. So tailoring the personalized medicine may involve risk stratification to determine the aggressiveness of the treatment needed and the frequency of the monitoring. Bladder cancer surveillance, cystoscopy, and early check in a high grade is again an example for risk stratification and to personalization to the patient's need. Like, for example, at the age of 95 or 90, if somebody has got a bladder cancer, they should have an expectant treatment that is to deal with them as needed. However, at the age of 60, you obviously have to treat them very aggressively due to their risk stratification, really. CT-IVU, I've just put an example here that has got quite a high sensitivity and specificity to pick up cancer in the ureters and in the kidney. And block resection, again, an example for how to personalize the treatment to these patients. This is one of my area of interest about the redefining the precision and curative potential with the block resection. And the reason I just took this example is that how we are changing our paradigms ourselves to deal with the surge in the cancer. And as the cancer is surging, I think our surge to control it is also increasing and changing the dynamics. For example, in the bladder cancer, the white light normal ordinary cystoscopy misses about 20% of the tumor, and hence there are new things have come into market. That is the narrowband imaging, PDD, that is the photodynamic diagnosis, and then conformal microscopy, that we can actually put a scope into the ureter, into the kidney, and actually see through a microscope the cells themselves where they are. You don't need to do a biopsy. You can actually see those cancer cells through a microscope deep down inside the body. So this is again a very advanced thing at the moment, and it's in practice, but it requires a lot of experience, and it's already in the market. And image 1S stores treatment to do the further diagnosis much precisely. These are some of the examples you can see on the left-hand side, the PDD, whereby the tumor is just so subtle in the bladder, but when the dye is injected and taken up by the cancer cells, it just glows up, and you can pick it up easily. This is again another example that it is just such a subtle tumor here, but when you do an NBI, that is a very simple treatment in this cystoscopy, which is called NBI, that is the narrowband imaging, can pick up the cancer cells much readily. And here also a subtle tumor here, which is the normal cystoscopy, and then by the PDD, it can be picked up very easily. This is just I'll quickly scroll through that. This is the part of the urology thing. Basically, meta-analysis shows that there was a huge variability of the bladder tumor resection. When we do remove the bladder tumor, you can see the single tumor recurrence between 3 and 21%, and the single tumors and multiple tumors between 7 to 46%. What it means is basically there is a huge variability between the outcomes when you do bladder tumor resection. How can we address that? So we came up with an idea that if we can decrease the variability and standardize the type of the treatment, this variability, that is the difference between the outcomes, can be changed. And hence, we had a thing called en bloc resection of the bladder tumors, whereby we remove the bladder tumor in one chunk. So I'm just going to play the video here just to show you that this is the bladder tumor. And this is one of the personalized medicine and way of tailoring the recurrence and tailoring the surge of the bladder cancer. So this is a new treatment which we have introduced. It has been there but I think it has been recently popularized. And fortunately, I was involved in the popularization of this type of the treatment. You can see, instead of doing the resection, some of the urologists, especially Professor Shahzad, who is present there, will appreciate it more, that instead of doing a TURBT resection, you can do en bloc resection, whereby you remove the tumor in one single piece, which is the way the cancer should be dealt with, rather than another in piecemeal. En bloc resection of the bladder tumor with a hybrid knife. This is another example, a very quick 30 seconds video, whereby you can see those bladder tumors and this new hybrid knife, how it can personalize and tailor the type of the treatment. It raises the flap, you remove the tumor from underneath, and you can see how this high jet injection raises the floor, and it cuts through and have a better outcome. All of these examples are basically to share with you all the ways and means of how we are personalizing and how we are actually making the surge under control. This is just to tell you that how we have changed the paradigm, that is the en bloc resection of the bladder tumor in one intact piece. It ensures a more accurate histopathology, minimize the risk of tumor, and potentially reduce the tumor seeding from the recurrence, and offer better visualization of the tumor base and margins, aiding in staging and grading of the accuracy. So you can see these examples are telling us that how we are personalizing this treatment, how we are handling the surge in one way or the other. The second example would be a prostate cancer, whereby we are now change the management of the prostate cancer by instead of doing a biopsy first, we are now doing the MRI first, which means that MRI has, over the period of time, has had a good diagnostic accuracy for clinically significant prostate cancer. We divide the MRI findings into pyroid 1, 2, 3, 4, and 5. And pyroid 1, 2, and 3, we don't get too much worried about it or too excited about it. However, if there is pyroid 3, pyroid 4, and 5 and above, the chances of positive biopsy is pretty high. As you can see here, that pyroid 2 and lower, the negative predictive value is about 96%, which is quite accurate. And we don't really do the biopsies, even though the PSA would be high. There is one important thing in it, that the family history in prostate cancer does make a difference. And people who have got 1 or 2 first-degree relatives who have prostate cancer, they would have a higher chance of having prostate cancer themselves. So that's why we are a little bit more aggressive in the treatment and the diagnosis of these patients. Kidney cancer, you can see the predictive outcome of that by 2035, the incidence would seriously increase to quite a high level. And again, as I said, that this is another 1-hour discussion, that why there is a cancer surge. But I think for the time being, we're going to address how we're going to deal with the cancer surge. So the global data epidemiologists forecast an increase in the diagnosis of incidence of renal cell cancer. And you can see in 2013, there were about 300,000 diagnosed incident, but with an annual growth rate of about 6.2%. Nobody knows why that is happening. People are working towards it, but our work is to see how we can control it. So just got a rough idea about the kidney cancer. Basically, you can see that blood in the urine, quite less now. We see less and less of the kidney cancers, with the blood in the urine. Most of them are incidentalomas, we call them. That is, you find them only incidentally when you do an ultrasound for some other reason. Pain in your backside, obviously that happens when the cancer is quite advanced. Unexpected weight loss, loss of appetite and tiredness, all of these signs are, should be investigated. The risk factors are age, smoking, obesity, and slide we can go back to. Obesity, high blood pressure, and treatment for kidney failure. And the kidney cancer prevention, you can stop smoking and maintain good, healthy life, generally speaking, to prevent that. Again, just to give you an example of how we can deal with this, this is really a great example of personalized medicine, whereby, if we can either, if the age of the patient is about 80 years of age and if the tumor size is 2.5 to 3 centimeters, you can do an active surveillance on these patients, which is called the small renal cell cancers, which can be managed by active surveillance. Obviously, a lot of people would not want that, and they want some active intervention. But certain factors have to be taken into account. For example, their health, their general condition, the medications they're on, and whether they would be able for a surgery. Once we make that diagnosis, then there are several ways of dealing with those. And the most common one nowadays is a partial nephrectomy, whereby you just remove the you remove the tumor wherever it is located, as you can see in these diagrams. Again, the size does matter. And if the size of the tumor is more than 5 centimeters, we try not to do the partial nephrectomy, because the chances of recurrence is quite high on that kidney if we do that. More active surveillance is, as I said, that is one of the treatments as well. There are a lot of clinical trials happening at the moment, whereby the stem cell therapy and target therapies, and as a part of the personalized medicine, we should be participating in those trials, which are of great value if we do that. Data sharing and collaboration, very important, because once we have a data sharing and collaborate with different centers, we do learn from each other, and the collaborative data does help in personalizing and changing the type of the treatment. Supportive care is obviously very important. Personalized medicine takes into account the holistic need for cancer patients, including the psychosocial and supportive care, and it addresses the emotional support system and management and the overall well-being of the patient. So in summary, increasing cancer search underscores the importance of tailored and personalized medicine. By customizing the treatment to the unique characteristics of each patient's cancer and considering their individual needs and preference, we can improve the treatment outcomes, reduce the side effects, and enhance the overall quality of the care in the fight against cancer. This approach not only benefits patients, but also contributes to the ongoing progress in cancer research and treatment. And hence, if the cancer is surging, our quest for controlling it and dealing with it also should surge. Thank you very much. And thank you very much again, Sayubi, for providing this opportunity, Professor Shabizadi, Professor Shazad, and Dr. Mubashir. Thank you very much, and the audience.
Thank you very much, sir, for such a nice and a very elaborative lecture on a very complicated topic. And really, I have been enlightened with very new things in your lecture. And before going into details, there are certain questions in the chat box, and I will just request you that people are asking about. The first question is that the recent studies are showing that PSA can miss over half of the prostate cancer. Can you comment on this, please?
Yes, that's a very good question, and thank you very much, Professor Shazad. PSA has got specificity and sensitivity. So the specificity for the prostate is there. There's no doubt about that, and it's a very high specificity. But the sensitivity to catch the prostate cancer is low enough. However, we cannot rely on PSA alone. There are other factors which we come into play. For example, if a young guy with the age of 45, for example, we are seeing more and more of them, and who has got a PSA of only 2, for example, but has got a family history of prostate cancer, that his father also had prostate cancer, we would really take it very seriously. On the other hand, a patient at the age of 75 has got a PSA of 2, the same PSA, 2 on 75 years of age. I think that we would be considering that as a normal PSA. The reason is that there are other things which can cause the rise in the PSA. For example, urinary tract infection. Some people have prostatitis. Some people would have even sexual activity can increase the prostate PSA. And PSA is only a substance which is released from the prostate, and it is not of any danger that if the PSA is high, and there is no reason to bring the PSA down. So it's a kind of an indicator. And you might say, I normally use the term that we have signals when we are standing in the road, and the signals are green, yellow, and red. So it's a kind of a signal which gives you an indication where you have to move on or where you have to just stay where you are. So, and it has to be taken into account. The second important thing about the PSA is that it is specific to the prostate, but the sensitivity of prostate cancer only comes when you are really looking for it. So not every PSA should be treated. It should be looked into with the context of that. And if some people who have a very large prostate will have a will have a high PSA as well, because the prostate number of cells are high and they will be producing more PSA. So it has to be looked into the context.
Shazad, are you there, or you missed? You're having problem with the internet. So
I think my voice was muted.
yes.
So
Yeah.
does COVID or long COVID has any impact or predisposed to the increased urological issues, including the cancer? So this is the question in the chat box.
Yes. Thank you. It is a controversial issue. That's number one. And so far, what we are seeing, there is no reported reports which have been confirmed. But what I have observed in my practice as well, that since COVID, the effect of the COVID has increased in the cancer surge, and the era after the COVID, this cancer surge has increased. There are many factors to it. Number one, is that the reason for it? Is it the COVID itself? Or is it the reason is that people were locked down and they did not have an access to the treatment for it? They didn't have access to the monitoring. For example, people used to go to their GPs or used to have their blood test or the ultrasound or follow-up scans, and the monitoring. Was that missed? So difficult to know, but I think there are ongoing studies at the moment to see the connection between the COVID and long COVID and the cancer surge. So the answer is, at the moment, there isn't any clear evidence to suggest that, but there are ongoing studies, and this is a question which has really raised a lot of eyebrows, and people are actually looking into it.
Thank you very much, sir, for this nice elaboration. This my question from my side is that you talk about the increasing incidence in the cancer in these days. My question is that either this observation is when we see on the in the size of the population, number one, that if there's an increase in the population of that area like UK or in European countries, or in the last 5 to 10 years, it is almost in the same percentage. Number one. Number two is that do you think that the risk factors have increased in that time, in this time? And lastly, that your data collection in the hospital have substantially increased, and this is adding more incidence and prevalence rates in your registries. So what do you think that this picture is truly depicting the facts, or increase in the population is adding, and somewhat good mechanism in data collection is highlighting this picture of increased incidence of cancers? So do you think that this is the real incidence which is reflecting in this data? And the second question is that what is the size of the maximum size of doing en bloc resection of bladder tumors? Do you think that in the larger tumors it is possible, because sometimes we have problem in evacuating those tumors when we do a bigger en bloc resection? Thank you, Ji.
Thank you very much, Professor Shazad, for two very important questions. Sorry, I didn't mention that in the presentation, and I was expecting this from you to ask, because you're a very experienced urologist. Yes, the size is very important in the en bloc resection. It's only 3 centimeter, and we normally, carry out an eyeballing to see that if it is a 3 centimeter, or an ultrasound, and then try to do that, because most important is to remove the whole tumor in one en bloc. Otherwise, what's the point in if we morcellate that or remove it in pieces? So you're right, 3 centimeter is the size, but I've been doing this for a very long time. So we have developed some different techniques to evacuate it, other than morcellation. For example, if it's a female, or if the urethra is not very tight, even a 5 to 6 and even 7 centimeter tumors, I've done en bloc resections in different parts of the bladder, and then I had inserted a nephroscope, and through a nephroscope, because the channel is big, so we can collect it through that, and then it can be squeezed. And also have developed a small endocatch to collect that into it and then squeeze it and remove it completely. So it has just got a very lot of advantages, especially in the tumor assessment. And also it has been published in the data that if a high-grade bladder cancer, you do an en bloc resection, there is really no need to go back in 6 weeks' time to do a check cystoscopy, which we normally do after a high-grade bladder cancer, because the chances of presence of detrusor is there, and then the chances of complete excision is there also. So that's the answer to the second question. The first question is the tumor registry. We are keeping a very tight tumor registry all along, and it hasn't changed in Europe especially. And the only issue is that, which you have rightly pointed out, there is a surge in the population, and that is due to the immigration policy in Europe. For example, as far as I remember, from 18 something to now, the population of Ireland was really fixed at 4.5 million, and 4.5 million, and then that hadn't changed for, I think, maybe 70, 80 years. But this is the first time I have seen and I've heard that the population has first time increased to about 5.5 million. So this is for a small country like Ireland, it's a big surge. So 1 million extra have come into, and there will be less immigration and more more people have immigrated into Ireland than immigrated. So that could also participate in the cancer surge. But what I was actually mentioning in the talk was that it's an anecdotal evidence. What I was telling you was that I have actually seen since the COVID era that there is a certain surge in the prevalence of the prostate cancer and sorry, of all the GU cancers. For example, we used to do, there are eight urologists, and it's only anecdotal. There are 8 urologists, and we used to do maybe 1 or 2 kidney cancers in a week. But now, every urologist together, I think we're doing about 5 every week. So this is a clear-cut anecdotal evidence that there are more kidney cancers, there are more prostate cancers, and there are more bladder cancers, whether they are due to the surge in the population or it is due to the COVID era. Difficult to know, only the time will tell. But the registry is, it's quite tight, and it had been very precise in getting it. But so inshallah, at some stage we will know the actual occurrence of that.
Thank you very much, sir, for an elaborate answer. Sir, Professor Shabi, do you continue for other question answer session, because there is a list of a lot of questions coming in the chat box?
We should. Qasim, do you have time to take a few more questions?
Sure. Sir, at your service.
Very good questions. Unless, yeah. So there's a very interesting comment from Professor Salma. Can you please, can I ask the other participants to mute themselves? This is a comment that I think, Shahzad, can you read this from Salma Kundi?
Sir,
it's in the chat box. It's a personal thing.
So
I can see that.
Sir, my mom was operated, and on her gastroesophageal junction is removed, and an adenocarcinoma. She's 82 years then. She was refused chemo because of her age. Her oncologist advised immunotherapy. She got 12 cycles of Tecentriq. It was stopped because of bad blisters of all over the body. She is now on steroids. It has improved her skin condition, but its effect is opposite to immuno. So what should be done in this case anyway?
I think, Salma, there is nothing to worry about. Steroids were just used to control the side effects. Not really. The immunotherapy works in a different way, and it is not as simple as steroids will reverse that effect, but immunotherapy would have had an effect when the immunotherapy was given, and any circulating cancer cells would have been dealt with by the immunotherapy, which is a biological treatment, and would have controlled it. So you don't have to worry about it. It was just the steroids are very low-grade suppressants to control the blisters and the side effects of immunotherapy. So there is nothing to worry about.
Allah bless you. Thank you so much.
Thank you, sir. Another question in the chat box. I think this would be the last question. How does cyber knife differ from radiotherapy? Can you please elaborate how cyber knife works? Yes.
Okay. Very good question. There is a very subtle difference between the cyber knife and the radiotherapy. Cyber knife is also the name is very very interesting name, but it certainly hasn't got a knife, and it hasn't got a cyber connection. But the radiotherapy is basically the linear accelerators which produces the X-rays, and they traverse the body and give the radiation to the area of where it has been targeted. So over the period of years, this has changed, and the linear accelerators became more focused and they became more precise. And then finally, the peak was the CyberKnife, whereby the computer-controlled, precise, stereotactic, directional, precise application of the radiotherapy is now done through a CyberKnife in the computed way. And in the pictures I've shown that it is a kind of a robotic thing, which is really precising type. So what it basically does is that it, for example, I'll give you an example. Before a radiotherapy, which is given to the prostate cancer, will have side effects on the bladder, which is situated just above the prostate. So it will have bleeding and dysuria and pain in the bladder. And also some of the radiotherapy will go into the rectum and cause rectal side effects and also in the pelvic bone. However, with the CyberKnife, the preciseness of the delivery of the radiotherapy is such that the side effects of the bladder and the side effect of the rectum and the bowel is not there. So basically, it obviates or it prevents the side effects in the surrounding area where the dispersion of the radiotherapy is. So that's all the difference between CyberKnife and radiotherapy.
And to add to this, sir, what's the precise difference between a gamma knife and a CyberKnife?
Sorry?
Between gamma knife and CyberKnife.
Not aware about the gamma knife, but I think it is the photon therapy, whereby the photons are given to that. I'm unaware that gamma knife is available in our centers, maybe.
Okay. Thank you very much, sir, for very nice elaboration and an excellent lecture on a very difficult topic. And really, we were very much enlightened to listen about the latest prevalence and incidence, a surge in this and a new treatment modalities in cancer. And I would like Professor Shabi Zaidi to please have his last comment on your lecture. Thank you very much from my side.
Thank you, Professor.
Thank you, Shahzad, and thank you, Qasim. Extraordinary lecture. It's a new thing that the dimensions of cancer are increasing and rapidly changing. So there was this lecture by Professor Azhar Raza last year. She came over to London at the invitation of the Royal Society of Medicine. She talked about the first cell. It's a book that she's written. I think you might have read it, Qasim. You know Azhar very well. She was professor at Columbia. And what she said in that lecture was that we're looking at to identify the mother of all maladies, that cell by itself, which is the primitive cell that actually leads to, it produces daughters which multiply. Now, what is that cell? I couldn't. Is it is the primitive cell like transformed cell because you talk about the DNA and variations, or is it something different? It's a very complex subject. That's one. Second thing, before you finish, because the time is running out, it's 1 hour already. What is this liquid biopsy?
Yes, it's again a very, it's a very, again, the names are very, I should use the word sexy, but I think it is a very, that kind of a name, which is a very buzz name. So basically the cancer cells in the body are continuously moving and shedding DNAs, and these DNAs are altered DNAs. And now the technology is present whereby you can, through the bloodstream, see those DNAs, the altered shedded DNA from the cancer cells, and you can pick them up. So all it means is basically take a blood sample and see if the cancer cell is present in that blood. So this is called a liquid biopsy. Basically, some people who would have had a treatment and are in remission, a liquid biopsy is done to make sure there isn't any circulating cancer cells or metastatic cells or any indolent cancer present in any part of the body, and that can tell us that if the treatment has really worked or not. And also it will become evident in matter of time when it will become